Good morning. Welcome to today's lecture. So for today's lecture, we will have a brief discussion on retention and relapse in orthodontics. As for the learning outcome, at the end of the lecture, you should be able to define retention and relapse, identify the etiology of retention and relapse, outline the methods of retention, classify the type of retention devices used in orthodontics, and also explain the theories of retention. So coming to the introduction, what is retention? Retention is maintaining the newly moved teeth in position long enough to aid in stabilizing their correction. So once the teeth are moved to their new positions, it is essential to maintain these teeth in that new position till they are stabilized. That is what is known as retention. However, relapse is defined as the loss of any correction achieved by orthodontic treatment. So it has been proved that teeth moved through bone using any orthodontic appliance have a tendency to return to their original position, and hence it is important to stabilize post-treatment, thereby providing the patient a functional and an aesthetic occlusion or a profile. Why is retention required? Usually, once the teeth are moved, the gingival and periodontal tissues will need a substantial amount of time to reorganize themselves. So it is essential to retain these teeth. Also, it is important to retain teeth which were in an unstable position, secondary to the soft tissue pressures, and also any changes brought about by growth um, need to be overcome by retaining these teeth. What are some of the destabilizing factors? The presence of any persistent etiology, continuous growth, muscle imbalance, stretched fibers, and also the presence of an unstable occlusion. So these are some of the destabilizing factors which you have to keep in mind. Now coming to the causes of relapse, failure to remove the cause of malocclusion, incorrect diagnosis and failure to properly plan the treatment, lack of normal cuspal interdigitation, arch expansion either laterally and or anteriorly, incorrect arch size and any disharmony, incorrect axial inclination, failure to manage rotations, and improper contacts. So these are some of the causes of relapse, and in a particular individual, one or more of these factors may play a role to cause relapse in that individual. There are various schools of retention. The first one is the occlusion school. It was Norman Kingsley as early as 1880 who suggested that the occlusion of teeth is the most important factor in determining the stability in new position. So you have to bear in mind that good interdigitation always aids in stability of treated results. So that should be the goal before you remove the braces from an individual. So you have to establish good interdigitation. And also the next goal is the apical base goal. It was Lundstrom and Macaulay and Nance who suggested that apical base is an important factor in the correction of malocclusion and maintenance of the stability of treated cases. So these are some of the schools of retention. Uh, uh, the next one is the mandibular incisor school proposed by Grieve and Tweed. The mandibular incisors must be placed upright or slightly retroclined over the basal bone. This is again an important thing, especially the lower anteriors, that's the mandibular incisors. So they have to be placed upright or slightly retroclined over the basal bone to prevent relapse. The next is the musculature school. It was put forth by Paul Roger. The necessity of establishing proper muscle balance is what is the importance of retention and to prevent relapse. So retention basically depends on the occlusion established, and the occlusion established must be within the bounds of normal muscle balance. And also occlusion and muscle balance established are dependent upon the amount of apical base available and the relationship of apical base to one another. So it is important to bear this in mind as to how the perioral musculature will have an influence on the newly moved teeth. So any negative influences have to be counteracted by adequate retention to avoid any deleterious effects from taking place. There are 6 theorems of retention put forth by RIEDEL. Theorem 1 speaks about uh, the fact that teeth that have been moved tend to return to their former positions. So that's theorem 1. Theorem 2 speaks on the elimination of the causes of malocclusion should aid in the retention of its correction. So it's outright simple. The elimination of the cause of malocclusion should aid in the retention of its correction. Theorem 3, overcorrection of malocclusion is a safety factor in retention. Overcorrection is a safety factor in retention. Theorem 4, occlusion is an important factor in retention. As we discussed earlier, proper cuspal interdigitation or a proper occlusion is an important factor in retention. Theorem 5, bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. So we again discussed this. The perioral musculature or the gingival fibers need enough time to reorganize themselves so that they do not have any deleterious effects on the newly positioned teeth. Theorem 6, lower incisors must be placed upright over the basal bone. Theorem 7, corrections carried out during period of growth are less likely to relapse because the growth will aid in creating enough space for these newly moved teeth, and hence corrections carried out during this period are less likely to relapse because the perioral musculature and the perioral tissues will adapt to the newly moved teeth as there is still enough growth left, and hence any corrections made during this period are less likely to relapse. Theorem 8, the further teeth have been moved, the less likely the likelihood of relapse. Theorem 9, arch form, particularly in the mandibular arch, cannot be permanently altered by appliance therapy. So any expansion or constriction you have undertaken cannot be permanently altered by appliance therapy alone. Theorem 10, many treated malocclusions require permanent retaining devices. So this is the current school of thought as well, to provide a permanent retention, that is lifelong retention for individuals whose teeth have been moved to new positions, either using myofunctional appliances or fixed appliance therapy. There are also 6 keys which you need to remember. These keys can help achieve stable results in the mandibular teeth. Key 1 is the incisal edge of the lower incisor should be placed on AP line or 1 millimeter in front of it. That is the apogonian line or 1 millimeter in front of it. This creates an optimum balance of soft tissues in the lower third of face. Lower incisor apices should be spread distally to crowns when the lower roots are left convergent or even parallel. Crowns tend to bunch up and a fixed retainer has to be used. Apex of lower canine should be positioned distal to the crown, and all 4 lower incisor apices should be in the same labiolingual plane. Lower cuspid root apex must be positioned slightly buccal to the crown of the same tooth, and lower incisors should be slenderized, that is IPR or proximal slipping as needed after treatment. Now coming to the duration of retention, there are cases wherein there will be no retention needed or limited retention needed, and there are cases wherein there is moderate retention. So limited retention is when there are cross bites anterior or posterior, dentitions treated with serial extractions, and corrections achieved by retardation of the maxillary growth once the patient has completed growth, and also dentitions in which teeth have been separated to allow for eruption of previously blocked out teeth. So that requires limited retention. Moderate retention in cases of class 1 non-extraction cases with spacing and protrusion of maxillary incisors, class 1 and class 2 extraction cases, early correction of rotated teeth to their normal position before root completion will also require moderate retention. And cases involving ectopic eruption or the presence of supernumerary teeth, corrected deep bites will definitely need retention. And finally, class 2 division 2 cases, there is need to have extended retention to allow for any muscle adaptation to take place. Now, coming to the permanent or semi-permanent retention, here cases of considerable generalized spacing, cases wherein there is severe rotation or severe labialing malposition of teeth, spacing between the maxillary central incisors with an otherwise normal occlusion. All these will eventually need permanent or semi-permanent retention. However, in many cases, to maintain existing aesthetics, extraction may not be done. So the only way to create space in such cases is through expansion. And in these cases, especially in the mandibular arch, they will require permanent or semi-permanent retention. So now we will speak about the different kinds of retainers. So retainers are nothing but passive orthodontic appliances that help in maintaining and stabilizing the position of teeth to permit reorganization of the supporting structures after orthodontic therapy. The types are removable, fixed, and active. And also there are certain ideal requirements of a retaining appliance. It should retain all teeth that are moved into desired positions or new positions. It should permit the forces associated with functional activity to act freely on the teeth. It should be as self-cleansing as possible. It should be reasonably easy to maintain or maintain optimal hygiene. It should be as inconspicuous as possible and also aesthetically pleasing or aesthetically good. So these are some of the ideal requirements of a retainer. Now coming to the fixed retainers. So what are the indications of fixed retainers? So maintenance of lower incisor position during late mandibular growth following closure of diastema, maintenance of bridge pontic space, compromised periodontal conditions with the potential for post-orthodontic teeth migration, prevention of rotational relapse, prevention of relapse after the correction of palatally erupted canines, especially if a proper overbite has not been achieved. So it becomes important to place a fixed retainer. And also finally, prevention of opening up of closed extraction space in adult patients. So these are some of the indications wherein you will be using a fixed retainer. Also, there are several advantages of using a fixed retainer. It reduces the time of the chairside time for the patient and also increases patient cooperation. It is used when conventional retainers cannot provide the same degree of stability as in Hollies. It is more aesthetically pleasing as the retainer is not usually seen. No tissue irritation, unlike what we may see in tissue bearing areas of Hollies retainer. No jiggling of teeth. Also reduced frequency of in-office visits, used for both permanent and semi-permanent retention, and is better tolerated by the patient. However, there are certain disadvantages to using fixed retainers. It is cumbersome to insert. It is a technique sensitive procedure. Also increases the chairside time for placement of the retainer. It is relatively expensive and also they are prone to breakages. And if the retainer is fractured, you have to remove the entire retainer. That is, if you place a retainer from canine to canine, you will have to remove everything, remove all the composite, clean up, and then replace the retainer. So it's a tedious process. And also, there can be areas of uh, uh, sensitivity or caries developing around the fixed retainers. Certain times the maintenance of oral hygiene can be compromised. Apart from these, there are no other specific disadvantages to fixed retainers. So now we shall discuss briefly on the removable retainers. These are the most frequently delivered retainers in routine clinical practice. These retainers are passive appliances that can be removed and reinserted by the patient at will. The most commonly used ones are Hawley's retainer. It is a removable retainer and it was developed by Charles Hawley in the 1920s, almost a century ago. Um, so it basically has clasps on molars. It has a full palatal coverage and a labial bow with the adjustment loops. So it can incorporate a bite plane for treating patients or for retaining patients who've been treated for deep bite. Also, the Hawley retainer can have modification. That is, the bow can be soldered to clasps on the first molars. You can also place C clasps on second molars and allow bow to run around the entire arch. Also, the labial bow can run between the lateral and canine, and you can solder a clasp to control canine. So there can be various modifications you can do to a Hawley's retainer. This is also another retainer known as a wraparound modification, that is 3 to 3 clip-on. It's mainly used for lower anterior area. It can be used to realign incisors and or to maintain lower incisor space closure. Used if posterior teeth, were well aligned pre-treatment. So these are some of the indications wherein you can use a wraparound modification. Essex retainer is quite a popular one now. So there are times wherein the patients come and ask for these kind of retainers. So it's quite a popular one with the patients because it's transparent and it's much more easier to wear and uh, sort of more aesthetically pleasing than a conventional Hollies. However, it was developed in the 1993 and it is nothing but a plastic removable appliance. The advantages of this Essex retainer are it is aesthetic, it is inexpensive, and the patient is more likely to wear it for a longer or a recommended period of time. It's very easy to fabricate. It takes around 10 minutes for the machine to compress the vacuum formed retainer, and it takes another 15 to 20 minutes for you to finish and smoothen the edges. It is less bulky, it has good strength, and it can withstand forces, and no adjustments are needed, and usually will not interfere with speech or function. There are retainers which can be used for delivering some active forces, and these are known as active retainers. These are nothing but removable appliances that correct irregularities and is eventually used or maintained in the oral cavity as a retainer. So there are two we will be discussing today. Number one, spring retainer. It's used to realign malpositioned incisors. However, it will usually require an interproximal reduction prior to appliance placement to prevent proclining the incisors, and also IPR increases stability because you would have flattened the contact areas and thereby it increases stability. However, if teeth are severely crowded, retreatment with bonded brackets is recommended, followed by fixed retention. So if you see that the teeth have relapsed and severely crowded, you have to retreat them with bonded brackets and then straight away go in for a fixed retention. The second active retainer is the modified functional appliance. This is used to manage relapse potential in class 2 or class 3 cases. So it's usually either an activator or a bionator. So these are upper and lower retainers joined by interocclusal bite blocks. These help in the maintenance of teeth within the arch while slightly altering the occlusal relationship. There's no point of use, there's no point in using them in adult patients as there's no vertical growth remaining. Also, there's no skeletal change, which can be affected by these retainers. Can only be used if no more than 3 millimeters of correction is needed. Um, the goal of these retainers is to hold the maxillary posterior segment and allow for eruption of the mandibular posterior segment anteriorly. That is in class 3 cases, sorry, class 2 cases. So these are some of the indications of an activator or a bionator. Now, how do you retain teeth when you've treated a deep bite? Here you have to control the overbite during the retention period, otherwise there will definitely be a relapse. Also, you can construct an upper removable retainer with a base plate to prevent the lower incisors from over erupting and maintaining a posterior occlusion. After stability is achieved, you can advise the patients to only wear them at night. So how do you retain teeth if you've treated an anterior open bite? Here you have to see it from two different perspectives. One is with a patient with a habit and a patient without a habit. What happens in a patient with habit is relapse usually occurs by a combination of molar elongation and incisor depression, and hence you have to control both of these. And in patients without a habit, relapse is usually due to elongation of the posterior teeth, mainly the upper molars, and not the incisors. And also it is important to control eruption of upper molars. How do you retain the lower incisors and what effects do they have? Skeletal changes, the mandible grows downward, forward, or it can grow downward and backward, causing increased lip pressure, which might eventually lead to a distally tipped incisors. So this has to be taken care of. And also the dental changes, any late mandibular growth, which is a major contributor to relapse, has to be checked for, and also it should be retained until mandibular growth has ceased. So currently there's no evidence to suggest that the third molar eruption can lead to lower arch crowding. So we're almost reaching the end of the lecture. So we shall just briefly discuss on the regime of retention. Retention must be planned before starting a treatment and should start immediately following active appliance therapy. Usually the duration of removable retainer wear is around 3 months of retention, whereas some authors suggest lifelong retention, with the current trend moving towards the latter. That is, we do retain the patients for their lifetime. And the most commonly used protocol for a removable retainer is 1 year full-time wear, followed by 6 months nighttime wear. The main reason for this is that it gives the supraalveolar fibers enough time to reorganize themselves. It usually takes around 232 days or so for these fibers to reorganize, and hence the retention has to be provided until this time has lapsed. So there's also one technique which you can perform to counteract the deleterious effects of these stretched gingival fibers, and it's known as precision or a circumferential supracrestal fibrotomy. It involves surgical sectioning of these affected fibers by passing a sharp narrow scalpel through gingival sulcus to a depth of 2 millimeters apical to the alveolar crest. So you're just incising these fibers so that they don't contribute in, uh, causing any relapse of these rotated or derotated teeth. So that's precision. So I think with that we've come to the last slide. With that, we shall wind up today's lecture. So today we have discussed what is retention and relapse. We've also discussed on the etiological factors and what are the different kinds of retainers, their advantages, disadvantages, where can you use them, when can you use them, what are the contraindications, and also we discussed briefly about active retainers, and we also have spoken about a surgical technique to retain derotated teeth. So we shall end today's lecture. Thank you so much for listening.